You're about to point a beam of pure, lethal energy at a patient's chest. Move it 2 millimeters to the left, and, well, you cure their breast cancer. But move it 2 millimeters to the right.
Yeah, you cause irreversible heart damage. It's incredibly unforgiving.
Right. And welcome to the deep dive. Today, we're opening up the Handbook of Evidence-Based Radiation Oncology to figure out exactly how medical professionals walk this impossible tightrope.
It really is the ultimate balancing act in medicine. I mean, truly.
It is, and we're going to distill the critical principles of a field where you have to somehow maximize the absolute destruction of a tumor while fiercely protecting the healthy tissue that's, literally right next door.
And in an evidence-based field like radiation oncology, understanding exactly why a treatment works, like on a microscopic cellular level, and how the physics of the beam actually behave, well, that's just as vital as knowing what the standard of care is.
Which is exactly our mission today. So whether you're a medical student prepping for your oncology rotation, or a young professional in the clinic, or just an insanely curious learner, we are going to make this massive, incredibly dense textbook digestible and practical for your clinical understanding.
Absolutely. There's a lot of data in there, but it all connects back to the clinic.
It does. But okay, I have to start with the most obvious glaring paradox here. I mean, we are taught from day one that radiation is a carcinogen.
Right.
It causes cancer.
Right.
So how on earth does it make sense to use a carcinogen to cure the exact disease that it causes?
Yeah, it's the classic question. And it really just comes down to intent and dosage. Environmental radiation exposure is haphazard, right? It causes random sublethal mutations in a cell's DNA that eventually, well, they lead to unchecked growth. Cancel.
Like getting too much sun or background radiation over years.
Exactly. But therapeutic radiation is completely different. When we direct ionizing radiation into a cell in the clinic, our goal isn't to mutate the DNA. Our goal is to utterly shatter it.
Wow. Okay, shatter it.
Right. We're trying to create what are called double-strand breaks. If a cancer cell sustains enough of these double-strand breaks, usually around 40 of them, the cell's machinery just gives up.
It just quits.
Exactly. It undergoes apoptosis, which is programmed cell death.
So we aren't just damaging the cell, we are overwhelmingly destroying its instruction manual. But you can't just deliver one massive lethal dose of radiation to a patient's chest or brain to achieve this, right?
Why? Absolutely not.
Because the healthy tissues surrounding the tumor would be destroyed too.
Exactly. The normal, healthy tissues simply wouldn't survive a single massive blast. And that biological reality leads us to the foundational concept of the entire field, which is fractionation.
Fractionation, so breaking it up.
Right. Breaking the total prescribed dose of radiation up into smaller daily treatments and spreading that out over several weeks.
Okay, let's unpack this. Because if you're breaking the treatment up, there has to be a biological reason why that helps the healthy tissue, but somehow still kills the tumor.
There is.
The handbook details the 4 R's of radiobiology to explain this.
Yeah.
So let's start with the first R, which is repair.
Yeah, so repair is the absolute cornerstone of why fractionation works. When radiation passes through tissue, it causes sublethal damage.
Okay.
Now, normal, healthy cells have highly efficient, well-regulated mechanisms to repair this sublethal DNA damage. Usually, they can fix it within just a few hours.
Oh, well, that fast.
Yeah, very fast. But tumor cells, on the other hand, are chaotic. They're often fundamentally defective in their DNA repair pathways.
So by giving just a fraction of the total dose and then waiting 24 hours until the next day's treatment, you basically give the healthy cells time to patch themselves up.
Exactly.
But the tumor cells, because their repair kits are broken, they just keep accumulating that damage day after day until it becomes lethal.
Precisely. You're exploiting the biological difference in their repair capacity. But you also have to consider the life cycle of the cell itself, which brings us to the second R, reassortment.
Right, because cells aren't just static targets. They go through different phases to divide and replicate.
Right. And cells are not equally sensitive to radiation at all times. They're actually most vulnerable, highly radiosensitive, during the G2 and M phases of the cell cycle.
Which is when?
That's right before and during actual cell division, when their DNA is physically exposed and fragile.
Yeah.
Conversely, they are highly radioresistant during the late S phase, when they are actively synthesizing and copying their DNA.
Okay, so when you fire that first fraction of radiation, you're mostly just killing the cells that happen to be in the vulnerable G2 and M phases on that specific Tuesday morning.
Exactly. The tumor cells that were in the resistant S phase, they survive.
Right.
But here's the trick. Those surviving resistant cells, they don't stop. They continue to progress through their cell cycle.
Oh,
Yeah, so by spreading out the treatments over multiple days, you give those resistance cells time to reassort or naturally synchronize into the vulnerable G2 and M phases. You basically wait for them to cycle into the crosshairs, and then you catch them on the next pass.
man, so it's not a single wrecking ball. It's a strategic, timed siege. You hit the fortress, wait for the guards to change shifts and step out into the open, and then hit it again.
That is a brilliant way to visualize it. Yes.
But wait, causality here. If we're constantly pausing the siege to let the healthy cells repair, and we're waiting for the tumor cells to change shifts, aren't we also just giving the tumor a bunch of free time to grow back? Like, how do we prevent it from just rebuilding the fortress?
And that exact problem is the third R repopulation. You've hit on the greatest risk of fractionated therapy.
Because it's trying to heal, too.
Right. The tumor isn't just sitting there taking it. It actively tries to proliferate to survive the assault. If you drag the treatment out over too many weeks, or say if a patient misses too many appointments,
The tumor wins.
the tumor will begin to repopulate faster than your daily doses can destroy it. This is exactly why radiation oncologists are so strict about avoiding treatment interruptions. You have to maintain continuous pressure to outpace the repopulation.
Wow, okay. Which brings us to the final R.
Yeah.
And this one feels like pure chemistry to me. Reoxygenation.
Yeah, what's fascinating here is the role of hypoxia, which it just means low oxygen levels in how a tumor defends itself.
Oh, right.
Radiation, specifically the low-energy transfer X-rays we normally use, actually relies heavily on oxygen to lock in the DNA damage. When the radiation beam enters the cell, it ionizes water molecules, creating highly reactive free radicals.
Like tiny chemical grenades.
Exactly, like
Yeah.
tiny grenades that severely damage the DNA. But oxygen must be present to make that damage permanent. It's a concept known as the oxygen enhancement ratio.
But tumors, I mean,
Ah.
they grow so fast and so chaotically that their blood vessels are usually a tangled, leaky mess, so they don't have good blood flow.
Exactly. The center of a tumor is often a dead zone with terrible blood supply. In animal models, we see that about 15% of tumor cells are completely hypoxic.
Wow. 15%.
Yeah, and because they lack oxygen, the radiation-induced free radicals can't lock in the damage. These cells are highly radioresistant, and they're kept alive by specific proteins like HIF1.
HIF1.
Right, which acts like a biological panic button, changing the cell's metabolism to help it survive without oxygen.
Hypoxia-inducible factor 1. Right.
That's the one.
So if the core of the tumor is practically immune to the beam because it has no oxygen, how does spreading the treatment out fix that?
Well, because as you deliver your first few fractions, you kill off the outer, well-oxygenated layers of the tumor.
Oh, so you're peeling the onion.
Exactly. As those outer cells die off, the tumor physically shrinks. The chaotic blood vessels inside suddenly decompress and open up.
So the plumbing starts working again.
Yeah, right. That previously hypoxic-resistant core suddenly gets flooded with fresh blood and oxygen. So by the second or third week of treatment, those inner cells have reoxygenated, and they are suddenly vulnerable to the free radicals generated by the beam.
That is incredible.
Yeah.
So the 4 R's: repair, reassortment, repopulation, and reoxygenation, they aren't just textbook trivia. They are the actual mechanical justification for why a patient has to come into the clinic Monday through Friday for 6 weeks.
They're the biological laws we exploit to win the war, yeah.
So, okay, we know the biology, we know why we pulse the radiation, but how do we actually make this beam of pure energy? The physical tools are just as important as the biology here.
Oh, absolutely. In modern clinics, we predominantly use linear accelerators, or LINACs. These are massive machines that use microwave technology, very similar to radar, actually, to accelerate electrons through a vacuum tube until they're traveling at nearly the speed of light.
Nearly the speed of light. And then what? Do we just shoot the electrons directly into the patient?
Sometimes, but usually no. Usually we smash those near light speed electrons into a heavy metal target, typically made of tungsten.
Okay, why tungsten?
It's extremely dense. When these incredibly fast, negatively charged electrons get close to the massive, positively charged tungsten nuclei, the electromagnetic pull is so strong that the electrons are violently yanked off their path and rapidly decelerated.
Kind of like slamming on the brakes in a sports car.
Literally. In physics, it's called Bremsstrahlung radiation, which is German for braking radiation.
Braking radiation, I love that.
Yeah, that sudden, violent loss of kinetic energy has to go somewhere, right? So it's emitted as high-energy X-ray photons, and these photons are what make up the treatment beam.
Okay, but once those photons actually enter the patient's body, how do they deposit that energy? Because they don't just burn a clean hole straight through like a laser, right?
Yeah.
The handbook highlights something called Compton scattering.
Yes. Compton scattering is the dominant physical interaction happening inside the patient at these high therapeutic energies.
Okay, can you explain that mechanically?
Sure.
Because reading the definition, I think it's a dependent on electron density but independent of atomic number. It's pretty dense. How does it actually work?
Think of it like playing billiards.
Okay.
The high-energy X-ray photon is the cue ball. It enters the body and slams into an outer orbital electron of a tissue atom. That's your 8-ball.
Got it.
The impact violently ejects the electron out of its orbit, sending it flying off to cause all that double-strand DNA damage we talked about earlier. Meanwhile, the photon, the cue ball, bounces off in a new direction with slightly less energy, ready to hit another atom.
Okay, the billiards analogy helps perfectly. And because this interaction only cares about how many electrons are packed into an area, so the electron density, and not what the actual element is, bone and soft tissue end up absorbing the radiation fairly equally.
Exactly.
The cue ball doesn't care if it's hitting a bone atom or a lung atom. It just wants to hit electrons.
Exactly, which gives us a much more homogeneous, even dose distribution inside the patient compared to older, lower energy X-ray machines. Those used to be severely blocked by bone.
That makes sense.
Yeah.
And there's a crucial clinical feature to using these high-energy photons, right? They have what's called a skin-sparing effect.
Yes, this is huge. When these megavoltage photons enter the skin, they don't dump all their energy immediately. It takes a few centimeters of tissue for that billiard ball chain reaction of secondary electrons to build up to its maximum intensity.
Okay.
So the maximum dose, the Dmax, is actually deposited deep beneath the surface of the skin.
Okay, here's where it gets really interesting. Wait, if therapeutic photons penetrate deep and actively spare the skin, how on earth do you treat skin cancer?
Right.
Like if a patient has a basal cell carcinoma right on the tip of their nose, wouldn't a photon beam just pass right through the cancer and deposit its maximum lethal dose into the healthy bone or the brain underneath?
That is exactly why radiation oncologists must master multiple physical tools.
Yeah.
For a superficial skin cancer, we don't use high-energy photons. We actually flip a switch on the LINAC, move the tungsten target out of the way, and use the raw, accelerated electrons instead.
Oh, because electrons behave differently in tissue than photons do.
Exactly. Unlike photons, which are just packets of light energy, electrons have actual physical mass and an electric charge.
They're tangible.
Right. Because of that mass and charge, they interact heavily and immediately with tissue. They dump all their energy very superficially, right at the surface of the skin, and then they essentially run out of gas and starve.
Wow.
There is a rapid dose fall-off, which perfectly protects the deep, healthy structures underneath.
So they hit the skin tumor, obliterate it, and go no further. It's incredibly elegant.
It is.
And we also have brachytherapy, where we skip the external beam entirely and place radioactive seed implants directly inside the tumor.
And the governing physical principle there is the inverse square law. It dictates that the radiation energy absorbed is inversely proportional to the square of the distance from the source.
So, simply put, if you move twice as far away from the radioactive seed, the tissue only receives 1/4 of the dose.
Precisely. It allows us to deliver a massive localized dose directly inside a prostate or cervical tumor, while the dose drops off so dramatically that tissues just millimeters away are completely spared.
So we have photons that spare the surface and hit the deep tissues, electrons that hit the surface and spare the deep tissues, and brachytherapy that radiates from the inside out. Let's apply this clinically, starting with the surface of the body, where we can use those electrons.
Skin carcinomas are incredibly common, and when they occur on the face, say on the eyelid or the lip, we are dealing with highly functional and cosmetically vital real estate. You cannot just blindly fire a beam.
Right, and this is where practical physics comes in. If a patient has a tumor right on their eyelid, treating it could easily cause cataracts or destroy the lens of the eye. So the doctor will literally place a custom tiny eye shield. I read it's often made of just 0.95 millimeters of lead, coated in ointment, directly under the eyelid over the eyeball itself.
Yes, and because we are using electrons or low-energy X-rays that don't penetrate deeply, that incredibly thin layer of lead is perfectly sufficient to absorb the remaining radiation, keeping the dose to the delicate lens of the eye at almost absolute zero.
That's amazing.
Or, for a tumor on the lip, placing a custom lead shield behind the lip to stop the beam before it hits the teeth and jawbone. That prevents osteonecrosis, which is a really painful bone death.
Okay, so that's the surface of the body, where skin and mucosa generally have the ability to heal and regenerate. But what happens when the beam has to pass near tissues that literally never grow back? The central nervous system.
Yeah, the CNS is the ultimate unforgiving landscape in oncology. The neurons in your brainstem and spinal cord, they do not regenerate like skin cells. If you destroy them, they're gone forever.
So the stakes are as high as they get.
Absolutely. Because of this, the handbook details strict mathematical hard limits of normal tissue tolerance that simply cannot be crossed. For the brainstem, the maximum lifetime dose is 54 gray.
Gray being the international unit of absorbed radiation dose.
Correct. And for the spinal cord, there is a strict, hard maximum limit of 45 gray.
And what happens if you exceed that? Because the text makes a very clear distinction between acute effects that happen during treatment and late effects that happen months or years later.
Well, acute effects in the CNS are usually caused by temporary inflammation. The radiation causes a little edema or swelling in the brain or spine, which might cause temporary fatigue or temporarily worsen a patient's neurological symptoms.
Okay, but we can manage that, right?
Right, we can manage that with steroids.
Yeah.
But the late effects, those are permanent, and they are what we fear most.
Like what? What does that look like?
If you exceed that 45 gray limit to the spinal cord, you risk severe radiation myelopathy. This happens because the radiation damages the delicate myelin sheath insulating the nerves and the tiny blood vessels feeding the cord.
Oh, wow.
Subacutely, a patient might develop Lermite syndrome, where simply flexing their neck forward causes a sudden, terrifying sensation of electric shock shooting down their spine into their limbs.
That sounds awful.
It is. But if the dose was massively too high, the tiny blood vessels die off entirely. It leads to permanent, irreversible necrosis of the spinal cord. It causes total paralysis.
So I have to ask a worst-case scenario question. A patient comes into the clinic. They have a tumor that is physically wrapped completely around the spinal cord.
Okay.
And the cord, as you said, can only safely take 45 gray. But the biology of the tumor dictates it needs 60 gray to be destroyed. Who wins? How does a doctor make that impossible choice between curing the cancer and paralyzing the patient?
If we connect this to the bigger picture, normal tissue tolerance always dictates the boundaries of care. Always.
Always.
You cannot paralyze a patient to cure a tumor. The cost to their quality of life is unacceptable. Yet strict biological limitation is the exact reason why the entire field evolved to invent intensely modulated radiation therapy, or IMRT. Okay, so how does IMRT solve that impossible math problem?
By painting with radiation. In the old days, we just fired large square beams from the front and the back. It was a blunt instrument.
Just blasting a whole area.
Right. But IMRT uses advanced supercomputers and a device on the LINAC called a multi-leaf collimator. Picture hundreds of tiny motorized tungsten leaves rapidly sliding in and out, constantly changing the shape of the beam while the machine rotates 360 degrees around the patient.
Oh, wow. So instead of a massive floodlight, it's like a million tiny, highly choreographed laser pointers crossing paths.
Exactly. It allows us to physically sculpt the high-dose radiation cloud so tightly around the complex, irregular shape of the tumor that the dose drops off a cliff right at the millimeter edge of the spinal cord.
That's unbelievable.
We can deliver the lethal 60 gray to the tumor wrapping around the cord while the cord itself receives a safe 40 gray. It is a triumph of physics over biology.
That is astonishing. And that same principle of sculpting the dose brings us to another highly sensitive area, which is the breast.
Yes.
The tightrope walk here isn't the spine. It's about protecting the heart and the lungs, while simultaneously using some incredibly advanced biology to change how long a patient has to be in treatment.
Breast cancer treatment is a masterclass in combining anatomical setup with advanced biological modeling. First, the physical setup. When treating the whole breast, the patient is simulated supine, so lying on her back, with her arms raised above her head to pull the tissue away from the chest cavity.
And they use tangential fields, meaning the beams don't point straight down into the chest. They come in sideways, at angles that just skim across the chest wall.
Exactly. The goal is to treat the breast tissue while minimizing the dose to the underlying lungs and, critically, the heart.
Because the heart is right there.
Exactly, especially for left-sided breast cancers, because the heart physically sits closer to the left chest wall. The handbook is rigid on this. We must keep the volume of the heart receiving even a low dose of 5 gray, the heart V5, to less than 5%.
And if you don't?
If we fail to do that, we risk causing long-term cardiac toxicity, like severe coronary artery disease, 10 or 15 years after we've cured the breast cancer.
That's quite the trade-off. But the biology is where breast cancer treatment is truly undergoing a revolution, right?
Hmm.
It relies on something called the linear quadratic model, and specifically the alpha-beta ratio.
Yes, the linear quadratic model is the mathematical foundation of modern radiobiology. It defines the alpha-beta ratio, which basically describes how sensitive a specific tissue is to changes in the size of the daily radiation dose.
So what does this all mean? Let me try to visualize this with an analogy. So tissues with a high alpha-beta ratio, like fast-growing tumors or skin, are like a pile of dry leaves.
Okay.
They are going to catch fire and burn up immediately, whether you toss a tiny match on them or use a flamethrower. They don't care about the size of the dose, they just react.
That is a great analogy.
Yeah. But tissues with a low alpha-beta ratio, like the late-responding fibrous tissue in the breast or the muscle of the heart, are like thick, heavy oak logs. If you just toss tiny sparks at them, like small daily doses, they can absorb it and shrug it off. But if you hit them with a massive blowtorch, a huge daily dose, they sustain deep, permanent damage.
Exactly. And for decades, we assumed breast cancer had a high alpha-beta ratio, like the dry leaves. So we used small daily doses over 6 or 7 weeks to protect the normal breast tissue, the oak logs, from cosmetic damage.
Right, because you didn't want to use the blowtorch on the breast tissue.
Precisely. But recent radiobiology research discovered that breast cancer actually has a much lower alpha-beta ratio than we originally thought. It behaves more like the normal tissue.
And because of that biological discovery, we don't have to drag the treatment out for 7 weeks anymore.
Right. We can safely use a technique called hyperfractionation for many early-stage breast cancers.
Meaning fewer fractions. So instead of 50 grays delivered over 35 tiny daily visits, we give slightly larger daily doses, but finish the entire treatment in just 3 or 4 weeks.
Because the math of the linear quadratic model proves that giving fewer, larger doses achieves the exact same tumor control without increasing the late cosmetic damage to the breast tissue. We're even seeing the rise of APBI, or accelerated partial breast irradiation, for highly selected, very early-stage disease.
Wait, how does APBI physically work? Because you aren't treating the whole breast anymore, right?
Right, we target just the surgical cavity where the lumpectomy was performed. We can do this using incredibly focused external IMRT beams over just 5 days, or, and this is amazing, by physically placing a small inflatable balloon catheter inside the surgical cavity, filling it with a radioactive brachytherapy source, and delivering the dose from the inside out over just a few days.
So we're moving away from the old, fearful, treat the whole area just in cases mentality to something mathematically and biologically precise.
It's an evolution. By deeply understanding the biological equivalent dose, the BD, and pairing it with those millimeter-precise LINACs, we are moving toward shorter, smarter, highly conformal treatments that drastically improve a patient's quality of life.
Man, we have covered massive ground today. We journeyed from the microscopic warfare of the 4Rs repair, reassortment, repopulation, and reoxygenation to the hard physics of Bremsstrahlung photons and electrons. And we saw how those principles protect the spinal cord, shield the eye, and revolutionize breast cancer schedules.
It requires an absolute mastery of physics, biology, and anatomy.
It really does. So as promised, a quick educational review for you, the medical learner listening right now. Before you head to your next rotation or step into the clinic, test yourself. Can you sit down and explain to a worried patient using plain language why those 4 Rs are the exact reason they have to come in for treatment multiple days in a row rather than just getting one massive dose? If you can translate fractionation into comfort for a patient, you truly understand the biology.
That is the ultimate test of clinical knowledge. And I'll leave you with this final thought. This raises an important question about where we go next.
Okay.
We talked extensively about how hypoxic, oxygen-starved cells are highly radioresistant and how they use the HIF-1 protein as a panic button to survive. Right now, we are entirely dependent on the fractionated beam to slowly shrink the tumor and let oxygen back in.
Right, peeling the onion.
But what if we didn't have to wait? What if future systemic drugs could be given intravenously to neutralize that HIF-1 protein entirely? Or what if we could artificially flood the tumor microenvironment with oxygen molecules exactly 10 minutes before the beam turns on?
Wow. If we did that, wouldn't we theoretically rewrite the 4 Rs entirely?
Yeah.
I mean, we wouldn't have to wait weeks for reoxygenation. We wouldn't just be reacting to the biology anymore. We would literally be changing the environment before we even turn the machine on.
Exactly.
That is definitely something
Yeah.
to think about the next time you look at a LINAC.
Thanks for taking the deep dive with us.